Yeah, from the first slide. And
Yes,
just
sir. So a
maybe take our
patient
network.
a
Yeah.
male patient, 23 years old, who works in a hotel, came to the OPD with chief complaint of pain and redness in the right eye. So the patient complains of pain and redness in right eye, which is not associated with discharge, photophobia, watering, or itching. In past history, he has no similar complaints in the past. There is no history of any foreign body fall. There is no history of any ocular trauma or surgery. There is no history of spectacle or contact lens usage. And there is no systemic illnesses. The personal history, he takes a mixed diet, normal appetite, no addictions, bowel bladder movements are normal. Treatment, he has not taken any treatment previously. Family history is not significant. So on ocular examination, the eyebrow, eyelids and eyelashes and interpalpebral fissure is normal. Conjunctiva circumcorneal congestion is seen. In cornea, there is a small round epithelial defect at 8 o'clock position in the periphery of the cornea, which is stained with fluorescein. The corneal sensations are intact. Sclera, anterior chamber, iris, pupil, and lens are within normal limits, and fundus is also normal. So the provisional diagnosis in my case is right eye showing marginal keratitis with differential diagnosis as flight 10, peripheral ulcerative keratitis, and
Sagarika,
yes,
are you done with the presentation or you have something?
that's an all now.
Okay. Okay. So well presented. I just had a few questions for you.
Yes,
So can you go back to the clinical picture, please?
is it okay, ma'am?
Yes. So, yeah, it's fine. So here, like you said, this is your provisional diagnosis is a case of marginal keratitis. So what do you think the etiology is here?
In case of marginal keratitis, I feel there will be like chronic blepharitis or any eyelid pathologies, which will irritate the cornea and lead to secondary infections. And it is mostly seen at the places where the eyelid is touching the cornea. Like here we can see it is touching at 8 o'clock position. So usually the marginal keratitis will be seen at like 2 o'clock, 4 o'clock, 8 and 11 o'clock positions, where the eyelid margins are touching the cornea.
Correct. So, if I may ask, so this you think that this is a case of marginal keratitis secondary to blepharoconjunctivitis or meibomitis or meibomian gland disease? What?
At first I thought it is like a flight 10 or like for me it was like that, but then as I evaluated the patient based on history, like he's having irritation of eyelids and all, so I could assume that previously he might have had any eyelid pathologies secondary to which this infection has occurred.
Okay, so what is like from the
It is an inflammatory condition.
okay.
Like it is caused due to a secondary infection, but pathology is mostly inflammatory.
Okay. So marginal keratitis secondary to blepharoconjunctivitis is not an infectious condition. Okay,
Yes,
so it is mainly inflammatory. Here,
inflammatory.
what you see is not a secondary infection. So if you or any other resident, this is an interactive class, right? Or is it,
Yeah, absolutely.
okay. So is there any other resident who would like to just explain what is the pathophysiology of marginal keratitis? You or anybody else? So what is marginal keratitis more lucidly known as in common language? Like what do we call, is it generally commonly known as? Okay. So, catarrh basically means inflammation of the mucous membranes. Okay, so that is why we call this is also known as the catarrhal ulcer. Now, can you explain what is the pathophysiology behind this?
In that,
Like
it
what?
is an inflammatory condition where there is the Staph aureus exotoxins cause an antigen antibody reaction which get deposited on the peripheral cornea. So that is the main underlying pathophysiology leading to the ulcer.
Okay, and it is a type of hypersensitivity reaction, right? So, what kind of correct? So, like someone mentioned, it's a type 3 hypersensitivity reaction. Okay. Now you will not see, so you may have come across many patients in the clinic who have a lot of meibomian gland disease, lot of blepharoconjunctivitis, but all of them do not end up having marginal keratitis, right? So usually this happens to people who are already systemically more, more prone to get a kind of hypersensitivity reaction. So these patients, they also have an underlying systemic hyperactivation. Okay, so like you mentioned, this is the Staphylococcus aureus colonization also has to increase to a load where the exotoxins that are produced by it, they cause a delayed type of hypersensitivity reaction. Now, can you describe the location? Like you said, this was at the periphery, but what is the characteristic feature of a marginal keratitis?
It is present mostly at 2 o'clock, 4 o'clock, 8 o'clock, and 11 o'clock position where the eyelid margins are
Correct.
touching the cornea.
Okay, then
And it is more
can you
commonly,
describe the what?
it is seen in the periphery as the, because in the peripheral side there will be more Langerhans cells, Ig, like immunoglobulins, so the reaction will be more prominent at the periphery rather than the central cornea.
Correct. So this is basically, it's a type of antigen antibody reaction. Okay. So here, this is not, you may not call it this as an early stage of marginal keratitis, because marginal keratitis typically starts with stromal inflammation. That is, you will see an infiltrate in the anterior stroma or subepithelial infiltrate is there. Typically seen in the at the periphery, like you said, at those particular positions where the eyelid comes in contact with the cornea. Epithelial breakdown usually occurs later in the course. Okay. Now,
Yes.
to begin with, these lesions are typically they are round. They can be either arcuate or oval, what you call, or round. And another characteristic feature is that you will always have a clear margin between the limbus and these lesions.
Yes, ma'am.
That is how you differentiate them from other types of peripheral ulcerative keratitis. So this is a classical sign that is typically seen in marginal keratitis. And what are the other differentials like that you would like to put forth,
One
like
is
in a case when you're managing? Yeah.
there is like peripheral ulcerative keratitis.
Okay. Before that, because looking at this lesion,
Because
you know,
there is a clear zone between the ulcer and the limbus, so we can rule out phlyctin because that is mainly present at the junction or more into conjunctiva or cornea. That clear zone will be absent in case of other differential diagnosis.
okay. And would you like any other etiology, like probably where you can find such a lesion at the peripheral cornea?
Again, peripheral ulcerative keratitis like Muren's ulcer.
Yeah, so
But
PUK is one condition, okay, but
Mm.
that comes later down. So when you have been asked in the differential diagnosis of staphylococcal marginal, the first differential that you would like to put forth is an HSV marginal keratitis, right?
Herpes
Have you
simplex.
seen any case of herpes simplex virus?
At present, I have seen central corneal lesions, but in
Okay,
peripheral, I haven't yet seen.
correct. So, okay, so have you read about the differences between an HSV? How do you differentiate between an HSV and a staphylococcal marginal keratitis?
Based on science, the herpes simplex ulcer will have characteristic branching pattern with knobbed ends when it is in the center.
No. So, HSV marginal keratitis, of course, is a type of epithelial disease. But then again, the dendritic pattern is not always seen. So, which are the other features? So, HSV will typically, like you said, these occur at 2, 4, 8, and 10. HSV can occur anywhere, okay, in the peripheral cornea. Secondly, like this this is an immune-mediated reaction, right? It's an antigen-antibody reaction. The HSV infection is a direct invasion by the HSV virus. So that actually is a direct HSV infection. This is not an infectious condition. It is a immunological condition, right? HSV, you do not see a clear zone in between the margin and the limbus, right? Okay, there are chats also. Somebody is answering. Can you all please unmute yourself and answer, please?
Yeah, I think Shaiban, please use the mic.
Hello, good evening, sir. Good evening, ma'am.
Yeah, hi, Shaman.
Yeah, so ma'am,
So it's
and
actually difficult to read. It's better if you just unmute yourself, introduce, and then, start answering. Like if you have any comments or any answers, please.
so ma'am, HSV keratitis, the location, it is not particularly localized to areas of lead contact. It can be anywhere on the cornea. And
Correct.
secondly, HSV keratitis, it would have an initial epithelial defect. Later on, when the ulcer progresses, then there will be a stromal invasion. Whereas in marginal keratitis, initially itself you can have a very aggressive stromal invasion, and HSV keratitis would have loss of corneal sensation at that place. In stromal keratitis, you may or may not have loss of sensations.
Yeah, excellent. And can you tell how these lesions typically spread? Like how does an HSV marginal versus an staphylococcal marginal spread?
I'm not very sure, ma'am, but then is it they spread centrifugally around the limbus only? I'm not very sure about the spread pattern.
That's correct. So the staphylococcal marginal, because like you said, it's a hypersensitivity reaction. It's an inflammatory condition. So it will spread circumferentially along the limbus. Okay, because that is the area where even, so if you, like the blood vessels also, they extend, 1 to 2 mm beyond the limbus into the cornea. So that is where the maximum kind of and even the Langerhans cells or immune complexes, the complement pathways are maximally activated at the peripheral cornea. So that is how the staphylococcal marginal spreads circumferentially, whereas an HSV infection usually will spread towards the center. Is that clear?
Yes, ma'am.
Yes,
Thank
ma'am.
you.
Okay. Coming back to you, Sagarika, can you just share your slide on the history, please?
Is it visible, ma'am?
Yeah. So the past history, I wanted to actually see the past history once. Okay, so you have asked history of similar complaints, there's no foreign body. Okay, suppose there was a foreign body and such small lesions also occur, when there is an underlying foreign body that is present. So what are the features that you would see in a case of foreign body like corneal infection?
In case of foreign body cornea, first there will be history, plus there will be epithelial defect and patient will complain of severe pain. And after removal of, in case if it is an iron foreign body, there will be presence of rustring as well.
Yes, of course. That is very clear. Just suppose that is very obvious on clinical examination if there's an iron foreign body. But in cases of foreign body which are, not very clearly seen, so these cases you will always see there is a mucus plug that is present on the corneal surface. Sometimes we think this is an infiltrate, but it's actually more commonly because the infiltrate not very commonly will form within such a short period of time, right? So you will typically see a mucus plug around the foreign body, and you will also see a leash of blood vessels, extending from the limbus to that lesion. So this is very typical when there is a foreign body in the cornea. Is someone saying something? Okay. So if there's a foreign body, you will typically see a leash of blood vessels, which is a classical sign of an corneal foreign body invasion. Okay. And they will be, either they can be deep stromal foreign bodies also, but you will always see a mucus plug that is hiding the foreign body. Okay.
Yes.
So the signs will always be very, like, patient will be extremely symptomatic, and there will be a lot of watering and redness. Okay, out of proportion to what you would normally see for such a small lesion. Okay, normally with such a small lesion, you do not expect that amount of photophobia, redness, and watering. But suppose there's a foreign body trauma with a foreign body, you'll always see a lot of watering and redness in the eyes. Then, okay. So contact lens, what history would you ask for a contact lens? So like you also said, another differential would be a contact lens related peripheral ulcer, corneal ulcer, right?
Yes.
So could you describe how does a contact lens related peripheral corneal ulcer look, and what are the other things that you must ask if the person says, suppose they have been using contact lenses?
If a person is using contact lens, first we'll ask him how he's using it. Is he maintaining the basic hygiene, hand hygiene, plus the solution which he's using for cleaning the contact lenses? Because any infection can go through the contact lens and it can lead to like keratitis, infective keratitis. So we need to ask that in history. Plus, in case of contact lens ulcers, it will be more in periphery, but there will be like ridges will be present. It will have a different presentation. The symptoms will be more in favor of an infective keratitis than an inflammatory keratitis.
Okay, but a contact lens related peripheral corneal ulcer is also an inflammatory reaction. It's not an infectious reaction. Okay.
Okay.
So the symptoms will be very similar to what you have in the case of staphylococcal marginal keratitis. Okay. And these all ulcers will also present at the periphery. They can either be a single lesion or they can be multiple confluent lesions. More importantly, what type of contact lenses cause contact lens related peripheral ulcers? Do you know what type of contact lenses, or anybody else can also take up this question? Okay, so they are mainly the silicon hydrogel contact lenses. So this is what you will be typically asked, that which type of contact lenses are more prone to cause these conditions. And secondly, the extended wear regime is more. Suppose you're wearing contact lenses for a very long period, or you're wearing the contact lenses overnight. Such patients will have a higher chance of developing a peripheral ulcer. Okay. Apart from this, there are other factors like the contact lens fitting. And like you said, the hygiene that the person maintains, it can be with respect to the solution, to the contact lens case, that if the hygiene is not maintained, of course, these kind of ulcers are also more commonly seen in those people, right?
Yes.
And what kind of systemic illness are you looking at when you see such patients?
The autoimmune conditions we need to rule out, like rheumatoid arthritis, SLEs.
Correct. What else?
Diabetes.
Diabetics.
Okay.
Yes,
Vaginal,
Akhila, you
have
were
you
saying
heard?
something?
Yeah.
Yes, I was asking for diabetic history.
Okay. What else?
Diabetes, tuberculosis.
So PUK is seen in what conditions? Like you said, you would ask an history of autoimmune condition because you're suspecting PUK, right?
Yes, and most commonly PUK is seen in patients who are having rheumatoid arthritis. They are more
Okay.
prone for it.
Which other condition, which other autoimmune condition? Rheumatoid arthritis is of course very common, but what else?
Sjogren's syndrome.
Sjogren's, okay. Then
SLE, vaginal granulomatosis, but it is
correct.
competitive.
So of course, it's less common, but vaginal is also very important in because and what systemic features does a patient of vaginals have? When you're doing a clinical general examination, what would you look at? A saddle nose deformity that is commonly seen in patients with vaginal granulomatosis. Okay. So when you see such patients, always rheumatoid arthritis, of course, you will see deformities of the fingers and the distal joints. But in cases where you are suspecting any less common condition, you should always look for a saddle nose deformity, okay, and other things which may be indicative of an underlying autoimmune condition, right? So any other differentials that you would put forth in this?
Dellen,
Not really. Okay, so when would you suspect? So can you just go through what were the differentials that we discussed?
so peripheral ulcerative keratitis, then HSV, herpes simplex,
HSV marginal keratitis. Okay, number one. Then second.
second PUK,
Okay. Third.
and Fleichten.
Flickton, I would not put it right now. We just discussed foreign body related corneal trauma. Then
Foreign body.
Dr. Anuj is trying to help you. Contact lens related peripheral
Contact
corneal
lens,
ulcers. Okay. So
yes.
it's very important to mention the differentials in the order that the clinical picture more commonly resembles, right? So you would say HSC marginal, then you can say contact lens related peripheral ulcer, foreign body, and you forgot the most important.
Exposure keratopathy.
Exposure keratopathy, of course, but where do you typically see exposure keratopathy?
That would be at the 6 o'clock position in the clear cornea.
May I know who is saying, please? Please, can you introduce yourself?
This is Dr. Shaban here. So,
Okay,
ma'am,
Shaban.
I think exposure keratopathy would be more in the inferior between 5 to 7 o'clock hours, and it would be little away from the limbus. It won't be limbal. It would be on the corneal area.
Okay, Shaban, but in exposure keratopathy, yes, like you said, it is most commonly seen in the inferior one-third of the cornea. That's more common. Also, you should have any other clinical, sign. Like there should, on evaluation, you will always have some evidence of exposure, like either maybe what conditions do you see exposure keratopathy in?
It would be because of lag ophthalmos, because of
Correct.
exophthalmos, because of these some few common conditions, even in maybe thyroid patients. So anything that is
Correct.
causing retraction or incomplete closure of the eyelids, some underlying
Correct.
condition that would lead with poor Bell's
Correct.
phenomena.
Yes, absolutely correct. So in exposure keratopathy, typically you will see a lot of superficial punctate keratitis, normally affecting the inferior one-third of the cornea. Following that, these will form ulcers. But ulcers are not such peripheral in those cases because the inferior limbus is somewhat, covered by the lower lid margin. And secondly, these ulcers are typically much larger in size, and they are, of course, the classical sign of an exposure keratopathy related corneal ulcer is that they are spread horizontally. So if there's a ulcer is oriented in a horizontal direction and an inferior one-third of the cornea, then it's more likely to be an exposure keratopathy lesion. But what is most important that you forgot to mention, Sagarika, was actually a microbial keratitis.
Okay.
So that should actually come in as a first differential. So your first differential would be an microbial keratitis followed by HSV related peripheral disease, peripheral ulcer, sorry. Then you have contact lens related. So PUK, things like PUK moles are way down in the list of differentials, right? Because this
Yes.
clinical picture it can be very, very early PUK, but then it is not classically, represent the clinical picture what you would see in a case of peripheral ulcerative keratitis, right?
Yes,
So,
ma'am.
microbial keratitis because of any cause, right? So, moving to the management, how will you manage these cases? Like, what will be your first step in such cases?
In these cases, we'll use low dose steroids and taper it over
Okay.
2 weeks.
So
Along
suppose
with
this patient, sorry, I didn't get you. Can you repeat again?
Lubricating eye drops.
Lubricating eye drops. Okay. So management, when you say, typically begins with diagnosis followed by your treatment. Okay. So first you have to establish the diagnosis. Right now, just looking at the clinical picture, you have given a provisional diagnosis, right? So how
Yes,
will
ma'am.
you confirm your diagnosis or how will you start your treatment? So before starting, of course, we need to perform a few investigations and tests. So how will you do those? Like what tests would you like to perform in this case?
In this case, first we are doing staining. We can take corneal scrapings if we are suspecting any infective pathology.
No, we can do a lot of things. We can run the whole corneal diagnostic. What are you going to do in this case? Like if this patient came to you in your clinic, what would you do? What would be the first test that you would do? Like you said, you will stain the corneal surface, right?
Yes,
You
ma'am.
want to check. What do you want to check?
We'll check if there is a epithelial defect. Is it taking up the stain?
Correct.
Any surrounding infiltrates are there or not?
You think the infiltrate will get stained?
No.
So you're not looking at the extent of infiltrate, right? You're looking at the extent of the epithelial defect. What else are you looking at when you stain such surfaces?
Ma'am, the extent and the area between the ulcerated and the
I'm sorry, someone trying to say something. I'm not able to. I can hear Shaiban probably, but there's someone else who's also attempting to answer, but I'm
ma'am,
not
to see
able to hear.
the extent of the ulcer so that we have a clear margin of the ulcerated area and the normal corneal area. That helps us in taking the scraping.
Correct. So, scraping, you would of course not. So, once you have established that, there's, of course, training helps you to know the extent of epithelial defect. Also, in cases of trauma, sometimes, suppose there is a kind of corneal wound is there, or if there is a concealed corneal tear, then staining will help you. In the sense, it will when you apply some pressure, like how you perform a Seidel test, a forced Seidel test. In those cases, suppose you apply some pressure and there's some kind of leakage. Normally, if very small leaks, 1 to 2 mm, you may not be able to appreciate much because the AC is maintained. And if the patient presents early, you may not be able to see it also in clinical evaluation. So once you stain and you apply some pressure on the globe, then you can also check if there are some minor leaks that are present. Okay. So normally in a case, of Sagarika, in a case of marginal keratitis secondary to blepharoconjunctivitis, would you see an epithelial defect at initial presentation?
Initially, there may not be any defect. It could be
Correct.
minor.
Correct. So when would you, such a patient, who comes to you with an epithelial defect, you would always take a scraping, right? Because what do you want to rule out?
We'll rule out any infective pathologies which could have led to the ulcer.
Correct. So what are the other signs that could be suggestive of an infectious pathology?
In case of infections, the symptoms will be more as like patients might be complaining of watering, discharge, photophobia.
Correct. I said, what are the signs that you will see on clinical evaluation in a patient of infectious? Like when will you suspect an infectious etiology?
In case of infection, there will be total circumcorneal congestion. In these cases, it might be limited to that particular area also.
Okay.
Like, ma'am, presence of infiltrates can give.
Who's answering? Can you please introduce yourself?
Yeah, ma'am. This is Ayushi.
Yeah, hi, Ayushi.
Hi,
So
ma'am.
presence of infiltrate. Okay.
Um,
Anything to do with the size of the lesion?
size.
So these, the blepharoconjunctivitis associated marginal keratitis are typically they are small, right? 1 to 2 mm. So any lesion which is more than 1 mm, or you see presence of infiltrate, or you see presence of stromal thinning, there is presence of stromal lysis, or you see an AC reaction, most importantly. So in those cases, you will always suspect that there is a possibility that there's an underlying infectious cause rather than a hypersensitivity reaction, right? In an immunological reaction, you will not see that much of an EC reaction. But whenever there's an infectious etiology, you will see some amount of cells in play. Okay. So suppose you scrape this lesion, okay, and what will you find on scraping? Like, what does one typically discover when you scrape such lesion?
After scraping, we'll send it for a gram staining, GIMSA staining to know the etiology, like which agent has caused this, like bacterial or fungal.
Okay, so what would you see in this case? What do you expect to see on a gram stain and a GIMSA stain?
It is an immunological condition. We may or may not see the staph.
Sorry, I lost you, Sagarika. Can you just repeat again, please?
It is an immunological condition, so there may or may not be, like we may or may not find any staph aureus in the scrapings.
Okay, suppose why do you say we may or may not find? So ideally, what should it be? Should staph be there, or ideally should staph not be there?
Ideally, it won't be there because it is caused by the toxins which have been already released there. So the active agent may or may not be present at that time.
Correct. So when you're looking at the slide, you will not see, you would, in a typical case setting, you will not see any organisms. In
Yes,
GIMSA, what do you expect to see in the GIMSA stain? You will see neutrophils because it's an inflammatory reaction, right?
Yes.
Yeah, so you expect to see the inflammatory cells and neutrophils. That is what you see on a GIMSA stain, right?
Yes.
Now, staph aureus, then what other conditions can also cause blepharoconjunctivitis related peripheral ulcers? Only staph aureus is not the only organism. You have others as well, right?
It could be bacterial, or there could be parasitic blepharitis or seborrheic blepharitis.
No, I'm talking about, so most commonly it is the gram-positive organisms, right?
Yes.
Of which staph is the most common. So which other species is also known to cause this condition?
Streptococcus.
Correct. Haemophilus, streptococcus, these are the normal common cells also which are found, right? So
Yes.
how will you know that whether this is, suppose the report comes out that staph aureus has been found in the culture, okay? So when do you know that this is actually because of staph aureus, or whether it is just a common cell that has been found on the scraping? So when do you call that significant? So for actual diagnosis, you would need a significant growth, right, on your culture. So when do you call growth to be significant? What are the cultures that you normally send on the samples?
For staining, like grams, GIMSA stain, then KOH mount or SDA.
No, staining is different. So staining, you would take a gram staining, and if you're suspecting fungal, probably KOH. GIMSA, we used to not do that commonly. I'm not sure if they do it at your place. I'm talking about the culture. Which culture plates would you normally send your samples in?
The nutrient-rich agar, like blood agar, maybe.
Correct. Blood agar, chocolate agar. Then for fungus?
For fungus, KOH, Sabrods, dextrose agar.
Okay.
Calcifluor.
And you will also send something like a liquid media, right? Like BHI, brain hard infusion agar, or a thioglycolate drop for anaerobic organisms, right? So when do you call the signal? So what is the pattern that you put the scraping on the culture plate?
In zigzag pattern.
Zigzag.
C-shaped, ma'am.
Correct. So C-shaped pattern, that is, so when do you call the growth to be significant, because see, things like gram-positive, like staph, strepto are normally also present. Like if I take your corneal scraping or your conjunctival swab, I will find these samples, right? But that doesn't mean that you have an infection, correct?
Yes,
So
ma'am.
how do you differentiate whether the condition is caused because of staph or it is just a common cell finding that you are seeing? So when you see a culture positive growth, right? So when do you call a growth to be actual culture? Like when do you call it a positive growth?
If the growth of the bacteria is following the pattern which we put it on the agar, then it is culture positive.
So along the zone of inoculation, right? Like you mentioned, if you see along that C-shaped streak, it is called. But to confirm that it is because, what is the definition of a culture positive organism?
We'll check for the colony forming unit.
Okay, and how many should be the colony forming unit? So typically when you have the same organism growing on two solid media, okay? Like you take whatever solid media that you're sending, So when the same growth occurs on two solid media, or it occurs on the whatever you are seeing on the scraping, along with that you also see it on a solid media, then you would confirm that it is actually not a common cell finding, but it is actually a underlying etiology that is causing that condition, right?
Yes, ma'am.
Okay, and what is the term that you use for these growths? Like, what kind of growths are these on the culture plate? So these questions I'm asking because they are very commonly asked in your exams, okay? So that is why. Otherwise, I do not have the intention to grill you guys. So these are confluent growths, okay? So when you see confluent growths on two solid media, or you see confluent growths on a solid media along with the same growth that you have seen on the scraping, when you stain the slides, you see the same, you will normally confirm the diagnosis, right? Okay. So moving ahead, okay, in this case, so why is it important? So any patient who comes to you with an epithelial defect, it is always best to scrape it to rule out any kind of infection, and then only start the patient on topical steroids. Okay, a person who is not having an epithelial defect and you can establish a clinical diagnosis of peripheral corneal ulcer related to blepharoconjunctivitis. In those cases, Sagarika, what your treatment will be?
So if there is no epithelial defect, we can use prophylactic antibiotics and lubricants.
Why would you use an antibiotic if there is no epithelial defect?
If you are suspecting any infections, so just for prophylactic.
No. So a case like this has come to you, and if this patient suppose did not have an epithelial defect, the patient had, like you define all the features, a 1 or 2 mm lesion at the corneal periphery with a clear lucid interval, no overlying epithelial defect, the lesion is anterior stromal. What would you treat that patient with?
We can just use lubricants maybe and follow up at a later date again.
Okay, the later date mein patient's clinical picture is the same.
2%?
So you would give steroids, right, to these patients? Topical steroids is a treatment, right? Because you
Yes,
said these are inflammatory conditions. So we would like to treat the inflammation with steroids, okay?
steroid.
And when would you start antibiotics? And why would you give antibiotic to this patient?
Like if there is secondary infection superimposing the defect, then we can
Correct. So
start.
any patient who's coming with an epithelial defect, you would like to give a prophylactic antibiotic to prevent any secondary infection, okay? So
Yes.
antibiotics are not given to treat the condition, it is just to prevent a secondary infection. The mainstay of treatment in these cases is topical steroids, okay? And what else would you like to treat in this patient? More importantly, you have to treat the underlying cause. Correct. So, what do you see in cases of blepharoconjunctivitis? What are the clinical features?
There will be matting of eyelashes, the crusts present over the root of cilia.
Okay. Matting of eyelashes typically occurs at the tip. So, when the tips are joined to each other, it's called matting.
Yes,
What do you see at the base of the eyelashes?
crusts will be present.
Right. So, you'll see crust, you'll see collarettes. Okay. What will you see on the eyelid margin?
The hyperemia will be present.
Is hyperemia the term that you use for eyelid
Tele-
margin?
Cells.
Yeah, correct. Akhila, can you just repeat that again?
Telangiectatic vessels, ma'am.
Correct. So you see telangiectatic vessels on the eyelid margin, right? And anything else that you would see? So you can sometimes see, loss of eyelashes. Okay. And very rarely you will see that there is excoriation of the skin, because these patients typically they start, they keep rubbing their eyes, they keep wiping their eyes. So in these cases, so it's important to treat the underlying condition first. So what is the treatment of blepharoconjunctivitis?
First, we'll advise hot fomentation and cleaning of eyelids with diluted baby shampoo or soda bicarb. And then we apply topical antibiotic ointments. If the
Okay,
infection
what ointment
is
will you like to give?
Azithromycin ion.
Okay, so azithromycin, okay. And would you want to give systemic medication?
if the symptoms are not subsiding and patient is still having the same condition, then we can prescribe systemic.
Okay, so it's not upon the based on symptoms, it actually depends on the severity of blepharitis, right? So you would like to give a macrolide or a tetracycline depending upon for a period of 2 weeks, depending on how severe the blepharitis is. Okay? And yeah, so anything, yes. Is anyone asking something? Any questions or any doubts, any other things, Sagarika, that you would want to discuss? Or anyone else wants to discuss? So as far as the history is concerned, it's important to ask, history of any foreign body or any history of ocular trauma. Then it's important to ask for a history of contact lens wear. It's also important to know whether the patient had similar lesions in the past. So why would you ask for that?
In patients who have autoimmune condition, there is a chance of recurrence.
Okay, but more commonly recurrence is seen in which condition?
In viral keratitis, we see recurrences.
Correct, correct. So HSP is something that presents as a recurrent disease. And while doing your ocular examination, it's important to stain the surface to know the extent of the epithelial defect. More importantly, I forgot to discuss, but you have mentioned it is performing the corneal sensation. Because viral keratitis, you may have a decreased corneal sensation in such cases. It's also suggestive of underlying HSP disease. Okay. And when you are asking for in case for suppose you're suspecting HSP, what history would you like to ask the patient for? So if there's any history of previous similar conditions in the past, and more importantly, if patient recently had any erythematous fever of URTI, okay, so in such cases also you're more likely to develop an HSP infection because the systemic immunity goes down. Okay. That's, I think, mostly done from my side. If anyone else wants to ask something, Sagarika, if you want to discuss anything else, or you want me to repeat something again.
So, ma'am, when the ulcer is not like if there is no epithelial defect, then we need to start on steroids or we can wait for some time.
No, you need to immediately start the patient on steroids because ulceration is the subsequent stage. You do not start with ulceration. As many the epithelial breakdown occurs at a later stage. So if you're treating the condition in the initial phases also, it is mostly using topical steroids. Okay.
Okay, ma'am.
So maybe a low dose topical steroid. So there have been studies where they have compared the efficacy of prednisolone versus a lower potency topical steroids, and they have not found any significant difference in terms of symptoms and the healing. So topical steroids are typically mainstay of treatment, but yes, if the patient develops an ulcer, then you will also have to give a topical antibiotic in combination to a topical steroid.
Ma'am, should we use only steroid or just for prophylaxis we can use antibiotic plus some low dose steroid?
No, absolutely not. No antibiotic needed if there is no epithelial breakdown. Topical steroids are for a stromal condition, if there only you will have to treat the patient with topical steroids. Antibiotics should only be started if you are suspecting an underlying microbial keratitis, that too after doing a scraping and after performing a complete microbiological workup. And when you're suspecting blepharoconjunctivitis, only to prevent a secondary infection, you can give an antibiotic, but not otherwise.
Okay, ma'am. Thank you, ma'am.
Yeah.
Anyone else having any doubts? Any questions if anyone has regarding management or regarding scraping, because that also got covered very nicely. So,
Ma'am, usually what steroid do you prefer, ma'am? Low dose steroids? I mean, low potent steroids.
I
Is it
actually prefer prednisolone acetate, but you can also use chloromethazone and it depends on the practice actually. So that is completely the choice. But what is my preferred drug is prednisolone acetate or loteprednol. If is a very small lesion and it's a very like an anterior stromal infiltrate is there, it's very superficial because low potency steroids do not penetrate, such deep. But if you're treating a superficial lesion, then low potency steroids are good enough. So you can start with steroids, yeah.
Thank you.
But you should not use low potency steroids with the fear that if something happens, then probably low potency can save you from, it's better compared to prednisolone acetate. That's not the case. So such
Okay.
patients require treatment with steroids, and irrespective of, once you have established the diagnosis of blepharoconjunctivitis associated peripheral keratitis, then you must use steroids. And antibiotics are absolutely not required in these cases.
Thank you, ma'am.
Anything else anyone wants to?
so we also did the same thing. We started this on steroids with antibiotic, and there was response. Okay. So this is, I think, the fourth day. We can see the epithelial defect is slightly going down, and by the 1 week, the lesion had totally scarred. So is there anything about scarring? Do they heal with scarring, or any pattern is there specific to these lesions? So this is the last follow-up picture. Hello. Is there any pattern for scarring, Dr. Supriya? Am I audible?
Yes, sir, you're audible.
Okay. Dr. Supriya? I think we lost Dr. Supriya's audio.
Hello, am I audible now?
Yeah.
Yeah, sorry, I was not able to hear for the past 1 minute.
Okay. So we started the patient on steroids,
Okay,
and we could see that slowly there was reduction in the congestion and the epithelial defect. So
okay.
this
Uh,
was the first day, and this was the picture. And then the last day, this is the picture.
yes.
So is there a pattern of scarring, Dr. Supriya? Like, do they?
So actually the pattern of scarring, it's not a point where you can differentiate between marginal keratitis secondary to blepharoconjunctivitis or a microbial keratitis. But of course, in cases of HSV, there is some pattern of scarring which are called as the footprint scars. But that you will only see when there's a breach in the Descemet's membrane. So those are not very superficial lesions that would cause that kind of a scarring. It's only when there are deep lesions you would see a footprint kind of a scar in those cases. But otherwise, the pattern of scarring actually is not a point where you can differentiate the underlying etiology.
So for such small lesions, do you scrape, or would you rather go for a trial of steroids, like practically?
No, honestly speaking, in this case, I wouldn't have scraped because this lesion is not very big, and there's like minimal infiltrate that is present with no AC reaction. The amount of congestion is also very minimal. And this is typically located at a lesion, at the site where you would normally expect a marginal keratitis secondary to, lid margin disease. So in this case, I would of course give a topical course, start off with a topical steroid. If I can follow up the patient very closely within a period of 2 days or 3 days, of course, I would not start an antibiotic. But if you feel that the patient is more likely to lose follow up or not be compliant, then of course it is good to start an antibiotic because there's an epithelial defect to prevent any kind of secondary infection. Did you start the patient on antibiotics?
Yeah.
Okay. Yeah, so likely, if there is presence of an epithelial defect, you can always start there's an antibiotic to prevent any kind of secondary infection. But scraping, no, because I don't really see it as a case of microbial keratitis. Of course, if there was more of infiltrate and AC reaction, then I would like to scrape it and then, just rule out secondary infection before starting steroids.
Also, one more point, Dr. Supriya. Few of the residents were having a query regarding the clear interval. So in this case, they thought that there is no clear interval between the clear cornea between the lesion and the. So is.
Yeah. So when we speak of marginal keratitis secondary to blepharoconjunctivitis, now this is the clear interval is more likely to be seen at the initial stages. When you have just you have an infiltrate without an overlying epithelial defect. In those cases, you will just see an subepithelial infiltrate or a anterior stromal infiltrate with a very clear lucid interval. Now, if you see this condition, when the patient presented to us, the patient already has, or rather to Dr. Anuj, the patient already has an epithelial defect, and you see there is vascularization. So, as the chronicity increases, in chronic case, when it is not immediate, when there is already a presence of epithelial defect, you will see vascularization. But still, if you can, there is some amount of clear interval in the sense that that part of the cornea is not affected by the lesion. You will always see blood vessels, like going across the limbus up till this lesion, because that's a normal how healing occurs, right?
So vascularization will always be seen, but still I would say there is some kind of lucid interval that is always present. However, it is much more clear in the initial stages, not at this stage when the patient is already, presented with an epithelial defect.
Thank you, because that was a doubt when marginal keratitis was presented as a diagnosis. A lot of residents, because that is a textbook criteria for marginal keratitis. So I think you have cleared that very nicely. And anything else, Sagarika, or anyone, before we let go of Dr. Supriya? We have last 2 minutes, I think.
So very nicely presented, Sagarika, and I'm glad that you asked the history of contact lens use and you performed a corneal sensation, because those are points that you would normally miss out. So it's important that you mention all these at least when you're presenting this in the examination.
Thank you, ma'am.
Perform these tests. I'm not saying just mention it, but you must perform these tests.
Yes, ma'am.
Right?
So I
Okay.
think we'll close down the session, and it was amazing having both Dr. Sagarika and Dr. Supriya. And it was really a great session of learning for me and all of us, and some great points which we can take home even for our practice. And thank you, Sagarika. And
Thank you.
hope we
Thank you,
can
ma'am.
catch up with Dr. Supriya again for some other topic.
Sure. It was really nice, and thank you for the opportunity. Looking forward to other sessions as well.
Okay, good night.
Good night, everybody. Thank you.